Hello everybody and welcome to our fourth Ask the Expert. I'm Maxine Tapp and I'm the Programme Development Officer for PSC Support and also a liver transplant patient. And I'm with Martine Walmsley, who is also a PSC patient and volunteer for PSC Support, as well as the Chair of Trustees. And we are delighted to be joined once again by Dr Andrew Yeoman. And today we're going to be talking about liver blood tests. So we've had a few questions sent into us in advance, but please feel free to also ask questions as we go along just by commenting on this post below, and we'll keep track of them and try and ask as many as we can in the half an hour that we've got. So thanks very much for joining us again, Dr. Yeoman. Welcome.
Thank you very much for having me again.
Okay, so shall I kick off with the first question?
Okay.
How important is alkaline phosphatase level in PSC, and can low levels predict better outcomes? And the person that has asked this says that their levels have never actually been elevated or raised, which means they've not been able to participate in any clinical trials.
Yeah, really good question. And I think there's lots of different facets to that question. So the first thing to say is that, yes, raised alkaline phosphatase levels can predict a more severe outcome in people with PSC in terms of needing transplantation or developing other complications of PSC. And most of the data comes from relatively small studies, which shows that if your alkaline phosphatase falls within the first couple of years of diagnosis, then you seem to be in a lower risk category for developing complications and needing a transplant. Where that's a little bit difficult is that not everybody whose alkaline phosphatase stays the same will develop a complication, and not everybody whose alkaline phosphatase improves will avoid a complication. But in general, if you take a large enough group of people, more people will develop complications of PSC and need a transplant if their alkaline phosphatase doesn't fall within the first couple of years. It's also interesting that a lot of the studies also show the alkaline phosphatase in those people who suffer adverse consequences from PSC tends to be higher than in those of people that don't. Some people may have heard of the UK PSC risk score. Martine, I know you were involved in that publication a couple of years back. And actually the change in the alkaline phosphatase or the alkaline phosphatase level at 2 years after diagnosis is one part of the UK PSC risk score, which tries to estimate what the risk is of developing complications at 10 years after diagnosis. So yes, alkaline phosphatase is important because if it falls, you're in a lower risk group. But that's not to say you'll definitely suffer problems if it doesn't fall. In terms of clinical trials, the reason why you're excluded from clinical trials is because they use alkaline phosphatase as what we call a surrogate marker of a better outcome. So because of those studies showing that if your alkaline phosphatase falls, you tend to do better, it's one of the things that drug treatments are targeting. Can we make the alkaline phosphatase fall? Because that might result and translate into benefits in terms of long-term survival with PSC. So that's probably why you're excluded from clinical trials. The final bit about that question raises a really important point about how useful liver tests are, or sometimes not are, in terms of identifying whether somebody's got a liver disease in the first place. And it doesn't always track severity, although in PSC, as I say, if your alkaline phosphatase is high and doesn't fall, you tend to be more likely to develop problems.
Excellent answer. And I would just add as well, look, we've asked patients before in the past, and I don't know how people who are listening right now feel, but it doesn't tend to reflect how people feel and function either, the alkaline phosphatase overall. And interestingly, so Maxine and I we speak to pharmaceutical companies thinking about bringing clinical trials to the UK, and some of them have now started not using ALK phos as part of the eligibility criteria, but as you say, they are using it to measure outcomes later. So they do measure it to begin with, but you don't have to have a certain level to get onto the trial, which I think is progressive. Actually, I think that's quite good.
Yeah, I guess one final thing to say about alkaline phosphatase as well is that it can go up for two major reasons in PSC. It can go up because you're developing progressive fibrotic and advanced underlying liver disease, but it can also go up in the short and medium term because of episodes of cholangitis. And so sometimes you can have cholangitis without having bad fibrosis or having cirrhosis underlying it. So the alkaline phosphatase does fluctuate quite a lot in PSC, And I think we need to recognize that as well. So it doesn't always stay the same.
Yeah, true. Okay, next question, a little bit wider. So if liver blood tests, well, they've written liver function tests, and we don't like that, do we? Particularly as a phrase, but you can explain why. So liver blood results are always on the high side, but not massively, and then bilirubin is within the normal range. So is it acceptable not to be seen by a PSC specialist team and just be seen by a local gastros team? So if you've got quite high liver blood tests but not massively high, and normal bilirubin.
Yeah, I think bilirubin is an important part of the liver blood test panel. We call them liver blood tests because they don't always, as you just alluded to, truly reflect the function of the liver, and crucially how much damage there may or may not be in the liver. So having said that, if you have a very high alkaline phosphatase, or if you have an elevated bilirubin as well, you are more likely to have advanced fibrosis and cirrhosis, or you're more likely to have more complicated bouts of cholangitis. So if your alkaline phosphatase is only marginally elevated and your bilirubin is normal, you're less likely to have complicated PSC or advanced PSC, but that's not invariably the case. So one of the most important things for anybody with liver disease, but especially for people with PSC, is we need to try and have a better understanding of who's got fibrosis and who's got cirrhosis or not, because most of the bad liver complications outside of cholangitis occur because of the development of cirrhosis and then what we call portal hypertension, which is where you can develop ascites, varices, and encephalopathy. So if you haven't got advanced fibrosis, then actually, if you've got a mildly elevated alkaline phosphatase and normal bilirubin, then actually, if you've got an interested IBD physician, if you've also got IBD with PSC, then actually you can get excellent care. I think so. It's about, there's many gastroenterologists out there who've got a good understanding of PSC, but if you've got a raised bilirubin or you've got advanced underlying liver disease, it is better to be under the care of a hepatologist as well. But if you haven't got advanced fibrotic liver disease and a normal bilirubin, then if you've got an engaged gastroenterologist, they should be quite capable of looking after your disease.
And would you say that there's a point in where that might change, so something happens where you should then perhaps be referred on to a liver specialist?
Yeah, I think the challenge with this on a UK basis is we haven't got enough hepatologists. We haven't got enough people with an interest and with the requisite training in hepatology. So there's always going to be a little bit of an element of shortage. But the red flags, if you like, for me would be certainly if you've got rising alkaline phosphatase that is persistently increasing, increasing frequency of cholangitis, or if you've got underlying cirrhosis, even if that's stable cirrhosis, I think it's very useful to have involvement from somebody who's more experienced with PSC.
Yeah, it's those changing numbers, isn't it, as opposed to the absolute numbers.
Yes, absolutely. So rising numbers or underlying significant fibrosis and cirrhosis, I think it's ideal to be under the care of somebody with a more specialist interest. But for many people, they can be well looked after by a gastroenterologist who does mostly inflammatory bowel disease.
Yeah, and we've just sorry to butt in on the questions, but we've just had one relating to all of this come up on Facebook, and the question is, would taking urso help reduce those levels? Yeah,
that's always a really good question, and the answer is most of us use urso in PSC, although some people don't use it at all. There's no convincing evidence that it changes the disease course of PSC, but it does make the numbers look better. It does tend to improve the alkaline phosphatase, and in people who stop it because of intolerance reasons, we often find that the alkaline phosphatase goes back up again. But we've never been able to convincingly show that reduction in alkaline phosphatase translates into a reduction in terms of the rate of development of scar tissue and cirrhosis within the liver and overall survival. So, but I think there's little doubt that the numbers do get better on urso, and they often get worse if you stop it for intolerance reasons.
Yeah. Do you find it there are, because I think there might be a small group of people for whom it does help. They actually feel better on it, and that's the case in PBC, isn't it, where that is actually used as a treatment. They have responders and non-responders.
I think that's a really good point. I think the first thing to say, we haven't got convincing evidence to say that it works. That doesn't mean to say that it doesn't work. We just haven't got the evidence to say that it works. We have to remember that PSC is the most rare of the autoimmune liver diseases. It's far less common than PBC. And actually, when I started out in gastroenterology, there wasn't good evidence that that urso in PBC reduced the likelihood of developing complications, but we now accept that it does. And that may be because, again, PBC is a relatively uncommon disease, and we've accrued the evidence over the decades that it does have a benefit. And it may be that we just haven't had the big enough studies yet, or looked at it in the right populations. As you say, there will be some people where it probably does have a benefit, but the studies haven't been able to tease that out as of yet. So most of us tend to use it because it is obviously there to try and improve bile flow. And if you've got bouts of cholangitis, that's kind of an attractive option, even though there's no convincing evidence it changes the overall disease course. But I think if it makes the numbers look better and you're tolerating it, it's a safe medication, then I think we all feel a bit more comfortable when the numbers look a bit better. And so I think a lot of us still use urso and PSC. The caution is that the backlash to urso and PSC came a number of years back when a trial in the US looked at high dose urso in PSC, and they found that people had more liver related complications from liver failure. But I think the patients that received it had quite advanced liver disease in the first place. So I think high dose urso is out, but urso at doses of about 15 milligrams per body kilogram, there's no evidence that that's harmful. It might improve the liver tests. And there's also this interest about whether it might modulate or modify the risk of developing colorectal problems in people who've got concurrent UC as well. So I tend to use urso as long as people can tolerate it. It does make the numbers look a bit better. And if you do stop it for any reason, the numbers do tend to get a little bit worse. But the jury's still out about whether it changes the underlying disease course and the need for transplantation. But watch this space, I suppose.
Yeah, that's a really good answer, and actually a really good explanation to, in the current PSC, UK PSC guidelines, the wording says we do not recommend using urso. But actually, the reason behind that is exactly what you just said, because of the lack of evidence, not because they definitely don't recommend it, if that makes sense. So it's good to talk about. Okay, so the next question is, what is considered to be very high or high ALT, ALP and GGT?
GGT is something that most labs don't routinely measure now because it's not specific to PSC, although it goes up in bile duct injury, and obviously PSC affects your bile ducts. Can go up with diabetes and go up with alcohol consumption, and certain medications can push your gamma GT up as well. And so because it goes up for lots of different reasons, a lot of labs don't routinely measure it. But it can, if your ALP goes up, then your GGT will also go up with it. What constitutes a high ALP? Well, coming back to that chat earlier about whether a high ALP is associated with worse outcomes, in some of the studies, people with a higher ALP at baseline and that didn't fall in the first couple of years after a diagnosis of PSC, the ALP was in the sort of 450, 500, so about 3 times. If it's more than 3 times the upper limit to normal, that's a reasonably high ALP. But again, we haven't got a clear cutoff which says ALP of X equals X% of needing a transplant, X% of developing complications. So, but in general, if the ALP is more than 3 times the upper limit to normal, that's around 450, then that's a reasonably high ALP. ALT is an interesting one. In many people with PSC, it'll be normal. But in some people, it can be the first abnormal liver blood test in PSC, particularly young people. Sometimes it actually looks a bit more like autoimmune hepatitis to start with, and the ALT can be 400 or 500 in some people, or 200 or 300, which is 5 to 6 times the upper limit of normal. So, but in many people, the ALT is normal or minimally abnormal. So we tend to see the alkaline phosphatase, the ALP, tends to be more abnormal than the ALT. That's the sort of classical picture of PSC, but it can sometimes present the other way around.
Thank you. So the next question, I'm going to read it out, and then I'd be very grateful if you could just explain it, because there's quite a few words in it that are not what we understand. So could Dr. Yeoman explain how PSC liver disease affects FBC and WBC differential?
Okay.
And they've added, I understand low platelets are linked to I can't say it, splenomegaly, caused by cirrhosis. But does this also cause a low white cell count? And does it affect all types of white cell the same, or are some usually lower than others?
That's a
So
good question.
I confess I don't fully understand this question, so I would really like you to help me understand it, please.
Well, it's a great question. I could plead the fifth and say this is about liver blood tests rather than FBCs, but I will answer it. So FBC stands for full blood count. So that's the sort of standard panel that we do, looking at hemoglobin, platelet count, and then the white cells. So WBC is white blood cells. And the differentials is there's lots of different types of white blood cell. There's lymphocytes, which are antibody-producing cells. There's neutrophils, which are important to the T cells, which are important for the functioning of the immune system. And there's other lesser types of white cells. But the main white cells that we measure are neutrophils and lymphocytes. Now, as the question alludes to, if you have advanced liver disease, so that's advanced fibrosis, scar tissue in your liver, or cirrhosis, and you have what we call portal hypertension, that's where your spleen becomes enlarged, then the typical thing that will happen on your full blood count is that your platelet count will drop. Not invariably, but what happens when the spleen becomes enlarged because of a scarred liver is that a lot of the platelets sit in the spleen, and then the spleen sort of breaks them down faster than it would normally do. So the total number of platelets in the body drops. But other blood cells, such as red blood cells, which is what we measure in the hemoglobin, will also drop a little bit. And the other white cells that are circulating will go through the spleen, and some of those will get taken out by the spleen. So what will happen is when your spleen is enlarged with significant liver disease and cirrhosis, is that preferentially your platelets will be more affected. The next most affected cell line is the white blood cell counts. And the next most commonly affected is the hemoglobin, the red cell count. So that's a sort of order of priority. Platelets get affected most, and the drop is greatest in the platelets. There's often a drop in the white blood cell count, and there's also a drop in the red cell count, but to a lesser degree than the white cell count. Now, in terms of does that affect the different types of white blood cells equally, it's quite a complicated one. There's not actually a lot of study on it, believe it or not, but what we find is that you generally find if the lymphocytes are low, then the neutrophils will also be a little bit low. So it can affect all the different types of white blood cells. If it's the spleen taking these cells out of the circulation and breaking them down quicker because it's enlarged. However, it can be more complicated than that, in that sometimes there's lower production from the bone marrow, and some cells might be reduced in their production from the bone marrow. And so sometimes you will get a slight reduction in only one type of white blood cell and not the other. But in general, if the white blood cell count is down, we tend to see a slight reduction in both the common ones, which are lymphocytes and neutrophils. The other thing that happens when you've got advanced liver disease and cirrhosis is that not only the number it can be reduced, but they don't function quite as well. So it's actually their function is as important as the number, because there's normally enough in number, even if the spleen is enlarged and it's taking some cells out of the circulation and the values drop in terms of the number. Sometimes if the liver is working well, they'll still function okay, and you won't suffer the consequences of that. So it's not just always about the number, it's also about the function. And as your liver disease progresses, that causes other knock-on effects. There's lots of different reasons for that, but there can be other knock-on effects which will reduce the function of the white blood cells. So it's a complicated question with a complicated answer. I hope I've answered it. Short answer is yes, white blood cells will drop, not quite as much as the platelets, but it can drop for more reasons than just the spleen being enlarged.
So there's always lots of interactions going on, and as hepatologist, you're just looking for patterns and just understanding. Yeah,
the liver is the liver is such a complicated organ, isn't it? I don't think people realise, unless you've got liver disease, I don't think people realise how much it does, how many functions it's got.
Yes, absolutely. And people forget about the immune function as well of the liver, and the way it signals to the bone marrow in terms of cell production, cell function. So it's more than just its metabolic functions of breaking down waste products. It has massive immune functions as well.
Yeah, very important organ. Okay, so the next question is about cholangitis, And do recurring attacks of cholangitis and elevated liver enzymes indicate more liver damage?
Good question. The answer is not always. So it comes down to whether some people have lots of cholangitis without serious underlying fibrosis and cirrhosis. Some people can have cholangitis and underlying cirrhosis. So in general, if you have an attack of cholangitis, your liver blood tests may go up. And coming back to the fact they are liver blood tests, not function tests, they may go up. But we know in lots of people with PSC, you can get atypical cholangitis where you just get a fever, you feel rotten, you get tummy pain, you might just have vomiting as the only symptom, and your liver tests don't change at all. It's not the case that just because your liver tests go up, that leads to more damage. That's not always the case. What we'll classically see is if you have a bout of cholangitis, but your liver's functioning quite well behind all that, is you might see a spike in your liver tests, the bilirubin, the alkaline phosphatase, sometimes even the ALT. But actually, once the infection calms down, they might improve and they might even go back to normal. That doesn't mean to say you've caused additional damage that way around. If you've got bad underlying liver damage, though, sometimes you might find after a bout of or recurrent cholangitis that the liver tests start to go up again and then never quite return back to normal. So yes, they often, but not always, go up in cholangitis, but it doesn't translate into that always leads to damage. It may not. It may just be simply due to infection and it will calm back down again, which is why the tests only tell you so much about how well or how damaged the underlying liver is. This is why other tests are often quite useful, whether that's biopsy, whether that's FibroScan, other ways of ascertaining whether the liver is damaged in the background. I find that a very useful tool in terms of risk assessing somebody with PSC and trying to give people guidance on whether they're going to develop problems in the short to medium term.
Piecing a puzzle together.
It is piecing a puzzle together, and I think I mentioned the PSC risk score, and that largely focuses on blood test parameters because that's what's widely available. And don't get me wrong, it's a brilliant score, and I use it myself in clinical practice. But I also find having knowledge of how much damage there is in the background liver is also extremely important, because if you look at the old literature around PSC, there was always this very alarmist that if you had PSC, then on average it was 9 years to transplant. Well, actually, we know that's not the case now. And actually, if you haven't got significant fibrosis and you've had PSC for 10 years, then actually, unless you get recurrent cholangitis problems, there's a good chance you'll avoid a transplant. So I think understanding whether you develop scar tissue having had PSC for a while is really useful to understanding how PSC is affecting you and affecting your liver.
Absolutely, because it always feels with PSC we've got bile duct damage potentially and liver damage. Yeah. And they can happen separately to one another, can't they?
Yeah. Or you can get both.
Yeah, or both.
So I think it's more than just what the liver tests will tell you. And I think that's why it's important to look at everything from every aspect, not just the liver tests, but also how much underlying damage there is, because I think that's really useful information.
Yeah, lovely, thank you. And staying on cholangitis,
yeah.
Is ciprofloxacin a good choice of antibiotic for cholangitis treatment?
Good question. Yes, it is. There's lots of what you probably find amongst people who use the support group is that if people have had cholangitis, they've had all manner of different antibiotics.
Yeah.
And it's not that one department is right and another is wrong. There's lots of different antibiotics that will be effective for the common bugs that cause cholangitis. The common bugs that cause cholangitis are ones that sit in the gut for obvious reasons. It's a sort of a communication process. PSC is largely a gut-derived condition. And so translocation of bacteria that are in the gut or getting up into the biliary tract, those are the sorts of organisms that will cause cholangitis. There's one called E. coli, is one of the commonest ones, and you can get Klebsiella, which is another gut-derived organism as well. So ciprofloxacin is a very good antibiotic for treating those types of bacteria. But different hospitals and different health boards and trusts will have a different strategy based on their local population, because some populations have different gut organisms than others. And so there are different sensitivities in different areas depending how often other antibiotics have been used in the local area. So the local microbiologist might say, well, actually, we've got a lot of resistance to ciprofloxacin in this area, in which case they might avoid using it. Or if you've had a lot of C. diff in the area, because ciprofloxacin can cause C. diff, and it's one of the ones we're a bit nervous about with C. diff. If there's been a lot of that in the area, then they might be a bit more reluctant to use it. But if that's not a problem in your local area, then they might be happier to use it. So, if most hospitals will have a guidebook, and it'll say for common gut infections, this is what we're happy for you to use. And that's based on local knowledge as well as drugs that we know will treat the common bugs that will cause cholangitis.
Thank you. I never knew that. That's really interesting.
Yeah.
Every day's a school day.
Yeah. Shall we answer some more I can see more questions coming on the Facebook. There's some pretty good ones coming in for you, Andrew.
Okay, let's go.
The first one, which I think a lot of people will want to hear the answer to this, is what is the guidance on use of the CA19 as a test? This person said prior to transplant, the level was over 2,000, which caused significant distress, but it was also told that his hepatologist was saying it wasn't very useful anyway. So I think a lot of patients worry about this test, and it causes a lot of apprehension.
Yeah. So increasingly, I think those of us who have a particular interest in PSC find this useful, and it works its way into guidance that it can be helpful to measure the CA19-9, but the context is the most important thing. CA19-9 is often used because it can be a marker. It's originally developed as a tumor marker for cholangiocarcinoma, bile duct cancer, but it goes up in cholangitis. It goes up in bile duct obstruction. If you have a stone causing obstruction to your bile duct, then your CA19-9 can go up. So the context is the single most important thing. So if somebody has had a bout of cholangitis, I don't find it particularly helpful to measure the CA19-9 at that time, but I do measure in people who are stable with PSC on an annual basis, because if you see a change, if it's always been normal and you haven't got cholangitis and it suddenly shoots up, it can be helpful in thinking, well, do I need to re-image the bile duct? Do I need to do an MRCP or another type of scan to look at the bile duct to make sure there's not a new stricture or a new problem there? So I think the CA19-9 can cause anxiety, but it very much has to be interpreted in context. If you've had a recent bout of cholangitis, it can be really, really high. If you've been jaundiced recently with that particularly, it can be really, really. I've seen CA19-9s in the several thousands just from an infection alone. So I think the trajectory, as Martine said, how it changes from one time to another is as important as a single value. And a single value isn't often very helpful.
So it is useful, but in a bigger picture. And if it is raised, then there may be several explanations as to why, and not just the worst case scenario. Absolutely.
Having a raised CA19 doesn't mean to say you've got bile duct cancer. It doesn't. It's not specific enough for that. It's used in the context of, if you're well with your PSC and it suddenly shoots up, then you need to have another look to make sure that the bile ducts aren't developing a problem. And some people may even have an ERCP depending on what an MRI scan shows. But a single one-off CA19-9 doesn't prove anything of itself. It's just a flag. It should be used in context. If there's no symptoms, then definitely have another look, further imaging usually. If it elevated after a recent infection, the first thing I would do is repeat it once the liver tests are looking better after the infection's cleared, because you'd often find it's gone back to normal.
Yeah, great, thank you. The next question is, this person's been wondering how often they should be getting blood tests done with PSC and UC.
Well, that's a good question, isn't it? So, again, context is the most important thing. It depends on your symptoms from your PSC. It depends on the stage of your underlying disease as well, I would argue. So if you have cirrhosis, I would say as a minimum, you should be having your blood test done every 6 months. Liver tests, and then I would tend to do a CA19-9 annually. You might do it every 6 months, but at least annually. If you've got concurrent ulcerative colitis, of course, there's a decent chance you're on drugs like azathioprine, in which case you'll be having your full blood count measured probably roughly every 3 months, in which case the liver test will often be monitored at the same time. I've got people that I look after with PSC that I see once a year, sometimes even every 18 months, because they've had it for a very, very long time. It's very mild for them. They know they can contact us if they've got any symptoms. They know how to manage it. And if it's very, very stable, then once a year is probably more than enough. But I think the key thing is people need to understand what to look out for. If your itching gets worse, it's always worthwhile rechecking your liver tests. If you're getting cholangitis, it's often worth rechecking it. That's your basic liver blood test panels rather than CA19. And as I say, I wouldn't advise doing an acute bout of cholangitis. So I think the context is so important. If you've got mild stable disease, once every 6 to 12 months is probably more than enough. If you've got advanced liver disease, minimum every 6 months. If you're developing signs of ascites and problems like that, you'd be having it monitored very, very closely indeed in case you might need a transplant assessment. So it depends very much on the stage of disease and your symptoms.
I think that's, and what you just said about if something changes and knowing what to look out for and when to do something about it is absolutely key for people with PSC.
Yeah.
Absolutely. So go on, sorry.
I'm going to say, and knowing how to contact your hospital or somebody in it, because so many people don't have that information. And it's, you know, as soon as you're worried about something and you want to know whether it's something to worry about or not, just having an easy direct contact is so important.
Yeah.
And I know you do that in Wales.
Well, I think lots of places do it, in fairness. I think care navigation, I think, is really difficult. And when I've been on the other side of healthcare, I don't always find that easy to engage with other departments. So it's not always that straightforward. And it is different everywhere. But I think the first point of call should be, you will almost invariably have a consultant that you're under with PSC. The first point of call should be the consultant secretary. It may be that they've got a nurse advice service. It may be they've got a consultant advice service. But the first point of call should always be the secretary. And what I always say to people is, if you've got a concern, what they'll need to know is if you can be specific with that concern, outline why you see the consultant you see, what has changed, what bit of information and knowledge do you need to get back, so that they can be targeted. And very often then they can do that much quicker for you. If it's phrased in a fairly generic, I need to be seen way, you might not need to be seen. You might be able to get a quicker answer just from saying, I'm a bit worried that my liver tests have gone off. I'm a bit worried that my disease has progressed. And they might have information they can reassure you quite quickly. So if you're specific about your question, you're more likely to be able to get a quicker answer back.
That's a great tip, actually. Yeah.
To put that on our website, I think.
Yeah.
Well, I think care navigation is still the single biggest challenge for anybody suffering with chronic health conditions, but particularly in rarer diseases. And I think, PSC Support is obviously working at that. The British Liver Trust are looking at things like patient charters. Knowing the right question to ask is challenging, but I think we need to have these conversations so we can encourage people to ask the right question, so you get the information that you need. And I'd say the more specific you can be in the question, the easier that is to answer very often, and the quicker you can get an answer back.
If we've got the time for just one more question.
No, it's fine. Okay. We got time.
So somebody's just referring back to what you said about having blood tests every 3 months if you're on azathioprine, and why is that? What are you looking for with those three monthly blood tests?
Yes. Again, very good question. So azathioprine can cause a reduction in your white blood cell count. It can affect the bone marrow production of white blood cells. And so what we do is, when people first start it, we measure that very regularly, because if it's going to happen, it usually happens when you first start the drug, but it can potentially happen at any time point on the drug. And so at the moment, the guidance is that you need to do it roughly if you're well established on azathioprine, every 3 months or so, to look if the white cell count falls. Because if it falls too low, and the one you're interested in is the neutrophil one, if the neutrophils fall very low, that's where you become susceptible to infections particularly. And if the neutrophils fall below 1.5, then you often need to reduce the dose of the azathioprine or even stop it. And that will allow the white cells to bounce back up again. So that's why we measure it regularly. Is 3 months the right interval? We don't know, actually. Some people have been on it for 10 years and they've been fine, and 6 months is probably fine for those people. But in general, it's there to measure, to make sure you're not developing a complication of the treatment that could increase your risk of infection. Because if you reduce the dose of the drug, then the levels bounce back up pretty quickly within a week or two. And then that minimizes the risk of infection.
Excellent. Thank you.
I can see another question here, just very quickly. Well, it might not be, because
she said
you'd think it would be a simple one, but I don't think it is. So what constitutes a normal blood result? So this question's about, like, how do you find out what the normal range is for liver enzymes? And that does vary, doesn't it, from males to females and so on?
It does vary, but not within a wide range. So ALT and it varies region to region. So ALT will vary, it'll be about 50 in females in some regions, 59 in men. ALP, if it's above 135 to 150, it's usually elevated. You can sometimes you can ask your consultant's secretary or the team for a printout of your blood results, and that will usually give you a reference range for the local lab. But if your ALP is above 150, 160, it will be abnormal. In the vast majority of labs. Bilirubin, anything above 20 is abnormal in virtually all labs, sometimes 18. So actually the range of ranges, if you like, it isn't that broad between different laboratories, particularly so for ALP and bilirubin. But if in doubt, you can always ask your local team if you're keeping records, because it's useful to know. But general rule, bilirubin, anything more than 20 is abnormal. Alkaline phosphatase, anything more than 135 to 150 is nearly always abnormal. ALT, anything above 50 odd, consider that abnormal.
And so our normal is the general population's abnormal sometimes.
Yes. Yeah. Yeah, absolutely.
I think that's a really good point though about if you want that information, asking your doctors if they can give you the latest your latest blood results and that reference of what's normal included in it, because I think sometimes people don't know that they can ask for that, and you get told, oh, everything's fine, and then you go thinking, well, what does fine actually mean for me? And so just asking that question, can I see my results? Usually it's like fine to get them.
Well, I think one of the things I think it's really important to get this message across is that when we see people in clinic, we have relatively short periods of time to do that. And that can be quite challenging looking back. If somebody's been looked after for 10 or 15 years with a condition, you may not be able to look back through all the different blood results. So actually, if you're interested in self-care and you've tracked that yourself, and you know what your normal ALP is, that could be really helpful in a clinic setting. Somebody says to me, oh, my ALP and it's 200 and it's normally only never more than 150. That says me going back and looking through all the others as well. So that really improves, and then you can spend more time in the consultation dealing with the consequences of that and what the next steps are. So actually, if you've got an open-minded clinician, somebody who's got knowledge of what their blood tests are doing in the past can be really, really helpful. It speeds up the consultation, not in terms of getting it over and done with quickly, but so you can focus on all the aspects that you need to focus on.
Yeah.
I have a tip as well, because sometimes you need to phone up your GP to get your liver blood test results. And I've found over the years it really helps to actually just write down in advance which of the liver blood tests you want to ask for. Because if you just go in and say, can I have my results? They won't read them out to you over the phone. No. You have to say the exact ones you're looking for. So that's my tip. Have it ready, and not just the acronyms, the full words, because they don't always know which ones they are straight away.
Well, it comes back to that point about being really specific about what information you want, so that makes it much easier to get the answers you want.
I think that's a really good note to end on, actually. So thank you so much again, Dr. Yeoman. It's been great to have you back, and we've discussed a lot, actually. So thank you so much for giving up your time for PSC patients.
No problem, that's a pleasure.
And before we go, I'd just like to say congratulations to your liver unit for getting your IQLS level 1, because that means that you're doing a really good service for liver patients, and you're the 4th unit in the United Kingdom to achieve this level. So well done.
Thank you very much.